Meet Ava, a 45-year-old woman recently diagnosed with stage 2 breast cancer. She has been told that she will need to go through a surgery and she has been researching her options. Today, she's going to meet her surgeon to talk about a novel surgery option known as a nipple-sparing mastectomy.
Let's talk about breast cancer. There are more than 150 new cases of breast cancer every day in the UK. It is the most common cancer in women in the UK, with one woman being diagnosed every 10 minutes. Today, we're going to take a look at one of the ways surgeons deal with stage 2 breast cancer, performing a mastectomy. However, studies have shown that mastectomies have significant patient dissatisfaction, giving way for innovative surgery type, a nipple-sparing mastectomy. Before we move forward, let's understand what we're talking about here. Mastectomy is a surgical removal of breast tissue. Patients with breast cancer might consider this as an option for treatment. Others might consider this procedure for prevention of breast cancer if they know they're at high risk. High-risk individuals include having a genetic mutation of BRCA1 or BRCA2, a strong family history, or a previous radiation to the chest. Here's the anatomy of the breast: the nipple, the areola, and the skin. Nipple-sparing mastectomy includes removal of breast tissue only. The nipple, areola, and some skin are not removed. This allows reconstruction of the breast to happen at the same time of mastectomy. This also allows a more natural-looking breast after reconstruction. What happens before surgery? The surgeon will usually draw landmarks on your chest, like this. The surgery takes place under general anesthetic. What happens during the procedure? In a nipple-sparing mastectomy, the incision may be around the lower portion of the nipple, with a line out like a spoon towards the outer breast or under the breast at the crease that is hidden. During the breast tissue removal, no skin is removed at the nipple and the nipple is left intact. The surgeon might take a biopsy from the tissue directly behind the nipple in order to test it for abnormal cells. Usually, the mastectomy, along with the reconstruction, takes 2 to 4 hours to complete. What happens after the surgery? You will be in the recovery room and your pain will be managed by medication. There will be a plastic drainage that collects fluid from the space under the breast skin. This will remain for 5 to 10 days after your surgery. After the surgery, you may go home on the same day or the next day of your surgery. For a period of 4 weeks after the surgery, you should refrain from lifting more than 5 kilograms. You will have some nausea or pain, and this will be managed by medication until they subside. There will be some exercises that you will need to do in order to maintain your arm movement and range of motion. You'll have a follow-up 2 weeks after your surgery for the doctor to review how you're doing and report back on pathology results of your biopsy. You also have a plastic surgeon. The surgeons will then discuss with you possible follow-up appointments if necessary. No routine imaging is needed. An annual clinical routine breast exam would be recommended. Future surgery might be needed for breast reconstruction. You should always ask your surgeon any questions you might have.
Let's check in with Ava. Traffic seems to have eased up. Ava has searched the internet to find information about a nipple-sparing mastectomy. She's seen many papers online but doesn't understand what they mean. She would like some clarity on them. She wants to preserve her nipple and is worried that losing it might lead to having body image issues.
Just like Ava, many patients opt for the surgery due to its psychological benefits. A study has shown upwards of 80% of patients satisfied or very satisfied with the appearance and shape of the nipple areolar complex after the surgery. Another study found that there is a good correlation between satisfaction with cosmetic outcomes and positive body image perception, sexuality, and self-esteem. However, this study reports a younger patient population who mostly belong to a higher socioeconomic background. In this study, nipple-sparing mastectomies and skin-sparing mastectomies groups are not directly comparable, as patients who underwent skin-sparing mastectomy also underwent nipple reconstruction, which introduces bias in the psychological outcomes reported by the patients. This is supported by another study that reports that patient satisfaction was not different in patients who underwent nipple-sparing mastectomies as compared to skin-sparing mastectomies plus breast reconstruction. Furthermore, an alternative paper shows that there has been some patient dissatisfaction in those with larger breasts with ptosis as nipple position alters post-surgical intervention, and it does not achieve the desired cosmetic benefit as promised by the surgery. It is important, therefore, to look at which patients were deemed suitable to undergo nipple-sparing mastectomies and reported positive outcomes. Some patients might have been deemed unfit for this particular type of surgery based off their cancer diagnosis, staging, or other risk factors such as smoking. Therefore, care must be taken before generalizing the benefits of this surgery to the whole patient population that presents with breast cancer.
After the surgeon explains the evidence talking about body image issues and the alternative surgery she might be eligible for to address her concern, she wants to know more about if she's suitable to undergo a nipple-sparing mastectomy. A systematic review investigated the inclusion criteria for 12 studies conducted in the area. The review shows that not all patients are eligible for this particular surgery. Patients whose tumours are more than 2 centimetres from the centre of the nipple and the size is 3 centimetres or less are advised that they can undergo nipple-sparing surgery. They should have negative sentinel nodes and no skin involvement, and also have no history of breast cancer previously. This makes a lot of people who have advanced stage breast cancer ineligible for this type of surgery. Some forms of breast cancer, including Paget's disease, are directly deemed ineligible for nipple-sparing mastectomies. Moreover, patients are generally young, healthy, and non-smoking with small to moderate-sized breasts. There are also most post-op complications if patients have a higher BMI or ptotic breasts, which make the benefits less generalizable to the patient population that comes in with high risk of breast cancer.
Even though Ava fits in the inclusion criteria for this surgery, she would like to know more about the risks associated with undergoing nipple-sparing mastectomies and any post-operative complications that might alter her decision to undergo this surgery.
The current literature investigates 2 major post-operative risks associated with this surgery. 1, nipple and skin necrosis, and 2, risk of cancer recurrence. Close to 9.5% of patients can encounter full or half-thickness skin flap necrosis. The risk of this is dependent on risk factors such as previous radiation, breast volume greater than 800 cm cube, and the periareolar incision placement, as supported by this paper. 2% of cases can encounter nipple necrosis, for which the high risk factors, again, are periareolar incision placement and radiation therapy. Where the necrosis is only partial, topical agents, conservative treatment is enough to heal. However, full thickness can lead to infection or even loss of implant reconstruction. Along with necrosis, nipple-sparing mastectomies have a higher postoperative complication in comparison to total mastectomies, where it's 8.1% compared to 38.9%. This includes formation of a seroma or a hematoma, which is known as the pooling of the blood underneath the skin, and also can lead to infections. Some papers have also talked about recurrence of breast cancer due to the retention of breast tissue, which would otherwise not be an issue in total mastectomies. Despite the potential complications of cancer recurrence, this particular cancer treatment has a low recurrence rate, meaning that it is unlikely that further treatment will be needed following a mastectomy. In accordance to the highly regarded Annals journal, the recurrence rate is only up to about 5% in those who undergo nipple-sparing mastectomies.
The overall evidence lacks long-term follow-up, suggesting low data of long-term risks versus benefits of NSM. Most studies are not standardized and have differing patient selection criteria. There is no consensus on surgical technique, selection based on pathology, etc., which shows low-quality evidence in favor of NSM for the general patient population that presents with breast cancer. However, for the specific patient populations included in the studies mentioned, the benefits of NSM are valid and cannot be denied.
In Ava's case, she knows what she would do. If you have any questions or concerns, do please reach out to your doctor to have a conversation.